Good morning, everyone. Thank you for the trainees joining in the YouTube to revise the questions for FRCS Urology Part 2 preparation. Today, we are continuing with technology. We will discuss various technology questions which could be asked in relation to prostate cancer. Anish, floor is yours.
Thank you so much, Mr. Danshagran. So, uh, you're in the technology table, and today we will focus on the technology related to cancer prostate. Because sometimes this happens like this, even if you are in the technology table, there will be a clinical scenario, and all the discussions will be based on the CA prostate technology. Sometimes that happens in stone, as it happened to me. So, all the discussions were based on stone technology, but the case will move forward along with it. So, uh, we'll start now.
Thank you.
Thank you so much. You have a 64-year-old gentleman referred by GP with a PSA of 5.8, repeat PSA of 5.9, no significant medical or family history, DRE is benign. So, what investigations you want to do afterwards?
So the investigations I would arrange for this gentleman is um, a pre-biopsy multiparametric MRI, and depending on the results, I would also arrange a trust biopsy.
Well done. Why multiparametric MRI?
So multiparametric MRI, the evidence around MRI before prostate biopsy utilized multiparametric MRI in the study. So talking about the PROMISE trial. And so the recommendation of NICE is to utilize multiparametric MRI.
Okay, well done. What are the principles of MRI? How MRI is taken, and what's the action of MRI?
So MRI scan works on the principles of the polarity of hydrogen ions in cells. So hydrogen ions will have the magnetic property on its own, and when this is brought in the field of an MRI scan, they will align and precess in uniformity. And when a radio frequency pulse is applied to the cells, then the hydrogen ions will revert to a perpendicular orientation, and removing the pulse of radio frequency results in the hydrogen ions returning to their natural states in two forms, called the T1 and the T2 decay. And this is picked up by the MRI machine and translated to images.
Okay, well done. So, what is meant by this T1 and T2?
So T1 means the T1 means the loss of. So T1 is when the hydrogen flips back to a longitudinal orientation.
Well done.
And T2 is loss of precessional coherence.
Exactly. So it all depends on the relaxation time of the proton. So if it relaxes back into its longitudinal direction, it is T1, and back into the normal or transverse direction is T2. How does it help? I mean, how can you differentiate a T1 and T2 in a prostate MRI?
So the way to differentiate is mainly by the appearance of fluids. So fluids would appear white in T2 images, whereas in T1 fluids will appear dark.
Okay. So you said about the multi-parametric. What are the parameters that we look for in a MP-MRI?
So this mainly constitutes 3 sequences. So T2 weighted images, contrast enhanced images, and diffusion weighted images.
Okay. What contrast we use for MRI scan?
Gadolinium contrast.
Okay. And how does gadolinium improves the accuracy of reporting the MRI scan?
So the principles is that in cancer cells you have hypervascularity and also blood vessels that aren't properly formed. So contrast will be quickly taken up and washed out in cancer cells as compared to normal cells.
Okay, so basically it speeds up the relaxation time, so we can get better accuracy or better resolution of the images. And compared to other images, what are the advantages of MRI scan in prostate?
So MRI scan gives excellent tissue resolution and differentiation between different tissue types, allowing for better interpretation. And the different phases as well will also help in the diagnostic accuracy of prostate cancer.
All right. Is DCE or dynamic contrast enhancement phase important in MPMRI?
So dynamic contrast enhance is important, especially in determining, for instance, whether a PIRADS-3 lesion becomes a PIRADS-4, or in terms of upstaging the PIRADS score. So that this is where dynamic contrast enhanced images become important.
Okay, so what is bioparametric MRI scan?
So bioparametric MRI is T2 image and contrast enhanced image, I believe.
Yeah, so recently we are moving away from the dynamic contrast enhancement in MPMRI. So now there are protocols where we don't have to use dynamic contrast enhancement. We can use it only for some special occasions where the patient already had biopsy previously, or if there is any previous history of prostatitis. So in confusing clinical scenarios, we can use the utility of dynamic contrast enhancement. But it is possible to get a PIRADS score with just the parameters T2 and the diffusion weighted image.
Diffusion weighted images, yeah.
And also So what are the limitations of MRI scan?
So the limitations are mainly from artifacts described as noise. So if they've got, for instance, a hip replacement, or if the patient is not able to stay still, then this will create artifacts in the pictures and make it difficult to interpret. More so for prostate cancer, if, for instance, someone has a biopsy before the MRI scan, then this will create artifacts. And so the advice would then be to wait for about 6 to 8 weeks post-biopsy before they can have a reliable MRI scan.
Well done. Have you heard about nephrogenic systemic fibrosis?
Yes, this is a systemic inflammatory systemic fibrosing process that occurs when patients, especially in end stage or patients in renal failure, have gadolinium contrast, enhanced MRI scan. And this is a multi-systemic presentation with fibrosis, skin contractures, ultimately leading to mortality of the patient.
Okay. Coming to the scoring system using the MRI scan parameters, can you tell me which scoring system we are using now?
So we use it. We can use the PIRADS version 2. Or the what's the other one called again? I'll talk about the PIRADS for now. So PIRADS is from PIRADS 1 to 5. PIRADS 1 being very unlikely, PIRADS 2 being unlikely to have clinically significant prostate cancer. PIRADS 3 equivocal, PIRADS 4 likely, PIRADS 5 very likely.
Okay, what's the difference between PIRADS score and Likert scale?
Yeah, Likert. So Likert, in addition to the radiological features, take into considerations things like the PSA density, DRA findings
Okay.
and the clinical picture. So while PIRADS is purely based on radiological features, LICATS incorporates some clinical information as well.
Well done. So, how does T2 weighted sequence help in diagnosing prostate cancer?
So in PIRADS reporting, the radiologist looks mainly at T2 pictures to report for the transitional zone. So this is the importance of the T2 weighted pictures.
What's the appearance of prostate cancer in T2 weighted images?
Sorry?
What's the appearance of prostate cancer in T2 weighted images?
So it'll be hypo intense.
Okay, well done. And what is the principle of diffusion weighted imaging?
So diffusion weighted imaging works on the principles that prostate cancer cells are hypervascular and disorganized, and so water molecules will diffuse, or the diffusion of water molecules is limited within prostate cancer cells as compared to normal cells, where you have better diffusion.
Okay, so it is a restricted diffusion, isn't it?
Yes. So restricted in prostate cancer cells. Yeah.
Okay, and how does it appear in? How does prostate cancer appear in diffusion weighted imaging?
So in diffusion weighted imaging, prostate cancer cells will appear hyperintense.
Okay, dark. So
dark, yeah, and then will appear whitish on the ADC map.
Yeah. So we have to be a bit more clear on that answer, because diffusion weighted imaging has got two components. One is the ADC map, apparent diffusion coefficient, and the other one is the B values. So apparent diffusion coefficient is what we see in the image. Because of the restricted diffusion, that area will appear dark. But in B values, it is like a derived value. So we, for prostate cancer, at least more than 1,000, but what we usually use is a B value of around 1,400.
Okay.
And it is the parameters are changed by the radiographer or a radiologist to achieve a B value of around 1,400. And in B value, the prostate cancer will be bright. So that's why. So in diffusion weighted imaging, in the ADC map, it will be dark, and the B values and the higher B values, the prostate cancer will appear bright.
Okay.
So there are two parts for the diffusion weighted imaging.
Yeah.
Even though we doesn't use MR spectroscopy nowadays, there could be questions on MR spectroscopy. Can you tell me about MR spectroscopy and the use in the previous use in the prostate cancer?
So MR spectroscopy, I'm not exactly sure how that works, to be honest.
Because it's not used nowadays. It was a big thing when initially the MRI came in early 2012 in that time. So MR spectroscopy works on the principle that there are two things that we look for mainly: the choline level and the citrate level. So the choline level is typically high in prostate cancer. Basically, it's because of the high cell membrane or cell turnover in cancer tissue. So when there is lots of cells there, the phospholipid content will be more. So the choline level will be very high.
Yeah.
But correspondingly, the citrate level will be reduced
in
cancer cells. So what they look is the ratio between the choline and citrate.
Okay.
So if there is more choline and less citrate, that is more suggestive of prostate cancer.
Yeah.
Not used nowadays. What are the contraindications of MRI scan? You said to me a couple of them, but can you tell me more about contraindications?
So contraindications include patients who've got ferrous materials, for example, shrapnels in the eyes. If they've got a pacemaker that's not MRI compatible, if the patient is claustrophobic, if they've got end-stage renal failure, or if they can't stay still for any reason, this will be contraindications to MRI scan.
Okay. And so your patient had the MRI scan. What type of biopsy do you do?
So I do a transrectal ultrasound guided biopsy.
All right. So it shows Gleason 4+3 in some significant number of cores. So you are discussing it in the MDT. The MRI scan shows that it is confined within the prostate possibly, but the score is 4+3. Do you need any more investigations before counseling the patient?
So I'll organize for a bone scan,
okay,
and a CT scan to fully stage this patient.
All right. What are the uses of bone scan in prostate cancer scenario?
So the uses could be in the initial staging of the patient, or it could also be for follow-up for patients who are already known diagnostic metastatic from diagnosis, to see how much they've responded to treatment.
Okay, well done. And what's the radionuclide used in bone scan?
So it's a metastable technetium-99 labeled bone scan.
So
bone scan
bone scan. So there is a lot of phosphonates related to bone scan, bone health, bone recovery. So you can remember it like it's MDP. Methylene diphosphonate. There is also, that's most commonly used in our hospitals. But there is another one called HDP as well, which is basically the hydroxy component of MDP.
Okay.
What is the usual dose of MDP that is administered?
I don't know.
Sorry. That is one of the questions I had one during the mock one. Okay. That's why I put it there. It was 600 megabecquerels.
Okay.
So how will you counsel the patient for a bone scan? What are the precautions that he needs to be aware of?
So I'll tell them to be well hydrated. I'll tell them that when they get to the radiology department, that the nuclear medicine tracer will be injected, and that they will be required to return or hang around there for about 2 to 4 hours before the pictures are taken, to allow good uptake in the bones. I would also want them to, after the scan, to stay away from any pregnant relative or anyone known to be pregnant. And also, this would be the main precautions, actually.
Okay. Yeah, one thing is right. It has to be well hydrated, and one thing most possibly, because there are some patients with bone positivity and really in pain, so we have to make them well aware that they have to lie supine in a couch for almost 40 minutes. So sometimes they will need to take more painkillers before the procedure. And there are mainly 3 phases of bone scan, which is the third phase is most important. So they may have to empty the bladder before the third phase to get a good picture, good imaging of the pelvic area. Because the technetium half-life is 6 hours, I'm not sure whether we have to stay away from the pregnant women, but I'll confirm that later. I haven't read something like that for bone scan. It's only 6 hours for the technetium, for the half-life of technetium. And because these emit gamma rays, and it's mostly diagnostic, it is not as problematic to the pregnant going near to the pregnant patients, as I believe, but I had to confirm that.
Okay.
What are the phases of bone scan?
I don't know.
So
I don't recall. Sorry.
No problem. There are 3 phases. Sometimes this question can be asked. This was there in one of the Bau's Viva scenarios. So the first phase is called dynamic phase. It mainly to demonstrate the blood flow, and the second one is again, it's a static image of the same thing, but it's against to demonstrate the blood pool.
Okay.
Mostly we don't get those pictures, and it's not usually not seen in the reports. But the third phase is the most important, and that's a phase when the images show bone metabolism.
Okay.
and it is taken 3 hours after the injection.
Okay.
And are you aware of the different techniques by which the bone scan is taken? I'm taking a bit more far because it's a discussion and you might not come in the exam, but if you know more, it is better, isn't it? So that's why I'm pushing a bit more regarding the bone scan, because
Yeah.
that's the one we usually prescribe for almost all, relevant persons who have a clinically significant prostate cancer. So,
Yeah.
do you know about the techniques by which we can by which we can obtain the bone scan images?
I know that this involves a gamma camera, but I'm not exactly sure.
Exactly. So
The different techniques.
There are multiple types of images that we can take. One is a whole body image.
Okay.
Or we can take spot views of certain areas that are of interest. Or
Okay.
the recent one is it can be combined with a SPECT, like a hybrid scanner. So we can get the bone scan images can be incorporated into a CT picture,
Yeah.
so we will get a better resolution and better anatomic orientation. The whole body image is when the camera moves along the length of the patient. Previously, it was like you had to use 2 cameras for the anterior and then go to the posterior. But nowadays, there are double-headed or dual-headed gamma cameras available, so you can get the anterior and posterior simultaneously. It will take almost 20 minutes to take that image. The spot views are when we have to focus more on certain areas of interest. Then we can take static images of that areas. And the SPECT is single photon emission CT, where we can either put like SPECT. We can just use the gamma camera to and a software where the software will reconstruct the bone scan images like in a CT scan picture. But otherwise, what we can use is a real SPECT CT where we can incorporate the gamma camera images into the CT scan images, where it will give a hybrid picture.
The main advantage of this is you will also get anatomical information apart from just the tracer uptake. So it will help us to differentiate, for example, rib fracture, because in the bone scan it will be just taken as a tracer uptake. We don't know whether it's a mix or not. But if you have the SPECT which is overlapping, you can diagnose even the old fracture. It is very useful in prostate cancer to make sure that we are not misdiagnosing a old fracture or old vertebral lesion like a vertebral collapse or any vertebral fracture as a tracer uptake, which may be misdiagnosed as a metastasis.
Okay, well done.
Okay.
And yeah, exactly. So that is one of the important points, because there are certain false positive findings in bone scan. One of them is rib fracture. Can you tell me other conditions which can cause a false positive things in the bone scintigraphy? Especially in that cases, we can use a SPECT CT.
So Paget's disease could also, and bone islands could sometimes be misinterpreted as hotspots.
Okay. So, because this is one of the definite questions that can be asked when it is a discussion on the bone scan. So, I would suggest to make it like a organized way in that answer. I mean, your answer is right, but still, to get to a good score, we can say that it can be traumatic, it can be degenerative or inflammatory disease, or it can be due to metabolic disorders, or it can be due to other benign lesions. The traumatic can be accidental or iatrogenic. The degenerative conditions are mainly arthrosis, osteoarthritis type of things. And metabolic disorders, especially hyperparathyroidism, has got a large bone metabolism, significant bone metabolism. So it can be shown as hotspots. And as you said, the benign bone diseases like Paget's disease, benign neoplasms can also show bone uptake. So it's always better to give it like in a systematic way, to give the outline like traumatic, degenerative, metabolic, and benign, and then explain onto that one. What are the limitations of bone scan?
I think we've already touched on the limitations of a false
positive findings, and also one of the other problem is gamma camera resolution is very low. So the
Okay.
small lesions can be missed. There
Yeah.
is some allergic reaction, although that is very rare, 1 in 200,000. But we have to always mention to the patient that there is a very slight chance of severe allergic reaction to MDP.
Okay.
And one of the limitation is super scan. So what is super scan?
Super scan is where the isotope there's so much bone activity that it's taken up by the bones, and the renal the kidneys are not outlined, or there's no outline of renal excretion.
Why there is no outline of renal excretion?
Because of the level of widespread metastasis,
Okay, well done.
which takes up all the radionuclide
Exactly.
isotope, such that none gets excreted in the kidney.
Yeah. So if we are unlikely to miss, but still, if it is, if you are, it can be mistaken for normal because only the skeleton lights up in the bone scan.
Yeah.
So going more towards the technetium MDP, what is technetium, and why do we have to combine technetium and MDP?
So technetium is the radio nuclide label, which is attached to MDP. Technetium is what generates the activity picked up by the gamma camera. Its half-life, as you mentioned, is 6 hours.
Okay, so what happens is when you combine technetium, for example, technetium is used in several other scenarios as well, like as in PET scan, but specifically for bone scan. So that is a radio pharmaceutical. The MDP will be taken up by the bone metabolism areas, and the technetium will tag on with the MDP when it is taken up by the high metabolic areas or high metabolism areas, and then once it is trapped in the cells, it will emit the gamma rays that's taken up by the gamma cameras situated outside the patient. Do you know how the radionuclide is generated?
So it's generated in the nuclear medicine department through reactors using molybdenum 99.
Okay, so that is the parent molecule.
Yeah.
What is the radiation dose of bone scan?
So it's about 6.7 millisieverts.
Okay, because I have read it like 4 millisievert in most of the books. So it's around 4. And as you said, there are 2 types that we can produce the radionuclides. If there is a cyclotron inside, then we can on the side, then we can produce the radionuclides from the cyclotron. But if there is
a what? Sorry,
it's called as a cyclotron. So where the parent molecule, the molybdenum, and we can then create all these molecules from the process or the machine known as cyclotron. So if there is a cyclotron on site, then we can use it. We can take the radiopharmaceuticals from on site. So we can use the radiopharmaceuticals with very low or very less half-life. That's the advantage of having a cyclotron on site. But if there is no cyclotron on site, then we have to supply the isotope to remote areas. So you have to use the pharmaceutical with a longer half-life.
Okay.
Coming to the PET scan, which is the more, I think that is coming more in favor in the prostate cancer scenario. What is the most common radio tracer used in the clinical practice for PET scan?
So it's choline for bone scan.
Okay. Okay. So
is it choline PET?
Yeah, choline PET is also falling out of favor. I will come to that. So the most common, the whole
FDG,
oncology scenario, exactly. Yeah, the whole oncology scenario, it is FDG. So
FDG,
what is the principle of FDG?
I'm not very clear on that.
Yeah, so how FDG acts is, FDG is fluorodeoxyglucose. It is labeled with 18 fluorine. And in the cancer cells, there is overexpression of mainly 2 things, GLUT1 on the cell membranes, and there is hexokinase inside the cells. So because of the GLUT1, there's a lot of GLUT1 in the cancer cells. The FDG will be taken up by the GLUT1s on the cell membranes and internalized into the cells. And in the cells, it is phosphorylated by hexokinase, and that will become the FDG 6-phosphate. And once it is phosphorylated, it is trapped inside the cells. So that's why we can use the imaging technique, the PET scanner, so that will be lighten up in metabolically abnormal areas.
Okay.
There are other options for prostate cancer. We'll come to that later, choline and acetate. But choline and acetate are mainly amino acid metabolism rather than glucose metabolism.
Okay.
How does the PET scanner act? What's the mechanism of action?
I don't know.
Yeah, so I'm saying it because there could be a scenario where the discussion can be only on PET scan, because we are utilizing it more and more on prostate cancer scenarios. So what happens is, just like the bone scan, we inject a PET radio tracer, most commonly used nowadays or approved one for prostate cancer scenario is gallium PSMA, especially in cases of biochemical recurrence. EAU guidelines says that we can use it when the PSA level goes more than 0.2. So what happens is, when you inject the radio tracer, it is taken up by the body and it is accumulated within the abnormal areas. And once it starts decaying, it will emit, say, positron. And once that positron travels away from the body, it will collide with the electron, and the process is called annihilation. That is taken up by the gamma cameras situated around the patient. So it's basically again a gamma camera, and that is like it's put it like a sensor all around the patient in a PET scanner, and then a 3D image is created with the computer. But FDG has got limitations in prostate cancer. The main reason is it is mainly there is good uptake by the kidneys and the bladder wall. So if there is good uptake by the bladder wall, and because it is very near to the prostate, it can cause false positive images, or it is very difficult to get a positive, to discern the positive areas when there is a more activity in the urinary tract. That's why FDG PET was not that much useful in urological malignancies. But later, initially it was like the choline PET CT scan, because choline is basically based on the amino acid metabolism, and there is a lot of choline activity in the prostate tumor cells. But one of the problem with the cancer choline was that there is a lot of choline activity and choline expression in BPH tissues. Afterwards, it was Flucyclovin. You might not need to know that. I put it in the discussion only to be aware of the PET scanners that were used and then fallen out of favor. So initially FDG, if you know these 4 things, that will be good for the PET scanning part of the technology. So start with the FDG, go with the choline and the Flucyclovin. And then what happened was that the PSMA PET came in. So you have to know about the PSMA PET, because that is the most, and that's approved one according to EAU guidelines. The others are approved by the FDA. The Flucyclovin is approved by the FDA. So focusing on the PSMA is prostate specific membrane antigen. So it is expressed in the surface of prostate cancer cells specifically. And it is expressed in almost nearly all primary prostate cancers and also in metastatic prostate cancers. And because the PSMA expression increases in the undifferentiated tumors, metastatic tumors, and also in hormone refractory tumors, it is very much useful in the prostate cancer scenario, especially even for the primary diagnosis, for the biochemical recurrence, and even to diagnose a hormone refractory state. And it has got good accuracy of around 80% in detecting the extraprostatic disease. It is nice to know about 2 more things regarding what we mainly use is the ligand-based PSMA PET. So it is what we use is gallium mostly, We can also use fluorine 18. So gallium PSMA is the one that is recommended by the EAU guidelines. But be aware that there is one more technology called the antibody technology. It's
Okay.
called Prostaskind. It has fallen out of favor after the gallium PSMA came into the clinical picture. Moving forward, your patient initially had the prostate surgery, then had the biochemical recurrence, which was taken up by the PSMA PET scan. You are starting him on ADT. So during the ADT, one of the concern is decreased decreased bone mineral activity and osteoporosis. So is there any way that we can look into the osteoporotic risk of ADT? Any imaging that
Yes.
helps us?
So you could do a DEXA scan, dual energy X-ray absorptiometry,
Okay.
to look at the bone mineral density.
Okay. What is the mechanism of DEXA scan? What we use in DEXA scan?
So it uses X-rays.
Mm-hmm.
It takes pictures of specific bones, for instance, the femur or the vertebrae.
Okay.
This is then compared to a fit population, so data derived from a fit population, the mineral density, and interpreted based on standard deviations from those values to generate a T-score. It's also interpreted in comparison to a cohort of similar age and race to generate a Z-score.
Okay. So basically it is X-ray, well done. So, and there are two beams of X-ray which are perpendicular to each other. And that's how we calculate the diffraction pattern. And you said correctly about the T-score and Z-score. Can you tell me once more, what's the difference between T-score and Z-score?
So the T-score is compared to a cohort of fit young patients, bone mineral density, whereas the Z-score is compared to a cohort of similar age and race to the patient.
Okay, yeah, exactly. So T-score is just sex matched, especially used for younger persons, and Z-score is matched for age, sex, and ethnicity. So there are three components in the Z-score. So I think we have come to the end of discussion for the prostate cancer scenario technology. I hope it was useful to you. I know I have pushed a bit more.
It was, thanks. Very useful.
Yeah,
I need to do a bit more revision in that area. So yeah
thanks. PET scan I would suggest, because each time the exam scenario changes, and we have to be in front of we have to think ahead regarding the exam.
Absolutely.
So
absolutely.
Mostly it will be fine with bone scan and DEXA scan, even X-rays, and sometimes CT scan. It can be asked, but I think moving forward we will be getting questions on PET scan. So
absolutely,
we have to read on PET scan, and not to the extreme, but still knowing that what is the basic principle of PET scan. It is just an extrapolation of what is in the bone scan, but the things change. Like it's positron rather than the other ones, gamma ray. In the bone scan. So these keywords, and then the methods that we use, the radiopharmaceuticals that we use, say more on the gallium. And if you are aware that there are other things but not that much used, and the limitation of FDG, because FDG is used in almost all other cancers, as we know.
Yeah.
So if we know why we are not using FDG PET in prostate cancer, I think that will be a real addition, so that we can cover all bases when you go to the prostate cancer technology part. I have because I know that it is going to be difficult, so I have put the PowerPoint along with the discussion.
Okay.
So
thank you.
You can go through that once you do the revision in the YouTube.
Yeah, no worries.
Thank you. I'm really sorry I pushed it so far, but you did really
well. No. Honestly, thank you. And it's clearly some knowledge gaps that need feeling. So I will go to work and hopefully I'll be fine.
You'll be fine. Yeah, thank you. Cheers.
It's very good. It's always better now rather than on the exam day, isn't it?
Absolutely. Yeah.
Very good. I will complete this with a kind of a suggestion and one question. And the suggestion is always try to remember the keywords. If you think the urology syllabus is very wide, so you will always, it's quite difficult to remember things as paragraphs or bullet points. If you may have gone through the video recording which we posted yesterday with the technology on BPH, Mimika. If you see, for everything there is a keyword. For example, if it is urolift means nitinol, capsular tap, stainless steel urethral plate. If you say about a suture means 0.4 millimeter and it works by apoptosis, you may need like 2 to 4, usually in even numbers, rarely odd numbers, like that. It's just keywords. And aquablation means it's based upon ultrasound. Use the word robot. May need something for hemostasis in the end. So like that, only the keywords, so that once the examiner says the question, 3-4 keywords should come to your mind like a light bulb. And you should make that keywords into a sentences. That will happen automatically. By remembering the keywords, you will never miss anything. So try to remember only the keywords, and of course try to write it in your own notes, and you will have gap between every table. So if you are now just going to the prostate cancer table, you can just open it. Keywords for active surveillance, keywords for surgery, radiotherapy, keywords for PSA screening. So it's very, very straightforward in the exam.
Okay, thanks.
Yeah, and I'm trying to finish this video by using a question so that the people who are not engaged in the video, when they are reviewing in the YouTube, they can answer it in the comments, so that we are going to make these sessions more interactive, so that even in the comments we can share some articles, some pictures, and ask some questions, etc. So the question for today is, what is the role of PSMA PET in biochemical recurrence? It could be due to post-radical radiotherapy for prostate cancer or radical surgery for prostate cancer. What is the role of PSMA PET in biochemical recurrence? We can discuss it in the comments. I will really encourage you also to post what do you think, what level you will decide PSMA scan, why PSMA scan, why not the old CT scans or bone scans, etc. We can have a good discussion parallelly. Okay?
Well done. Yeah,
Thank you.
Good. Well done. Anish, anything you want to add?
No, I mean, that's a good thing when we put the question in the discussion. I mean, even all of our subscribers who are in the channel, if they can put the questions in the comment section, we can always answer that. If it needs more clarification, it will be good for us as well, because some of the questions are really thought-provoking, that we can go back, review the literature, and see what's the latest in that one.
Yeah, because we have a comparatively a closed WhatsApp group, and we discuss so many important things for the exam. But if we discuss it in the comment section, it will be more reaching the people who are not in our WhatsApp group.
Exactly. Yeah.
Good. Okay, if there is nothing to add, nice session. So try to revise everything in one full sitting again, and we are quite happy to do the same session again if you want on a later date. And definitely when we are doing the 10 minutes technology sections, these kind of questions will come. Do not ignore the DEXA scan. The reason is two. Number one, number of things you need to read about DEXA scan is just only like 5 to 6 lines, literally. Number one. The most important reason is DEXA scan 99% is the last question in your 10-minute slot.
All right. Okay.
After the DEXA scan, only the examiner is going to pin your marks. So be very, very confident in the DEXA scan. The same thing applies to the other things like biochemical recurrence, post-radical nephrectomy, what is the follow-up plan. So those kind of tail questions, you should really nail it with the months and which guideline, which year, etc. Yeah.
Thank you.
Good. A good opening gambit, good tail question answers will really mask all the rubbish which, if at all, if we make in the middle.
Thanks.
Good. Have a good day, both of you. See you tomorrow for
Bye. See you later.
Bye. For you, we will see on Friday, isn't it?
Yeah, Friday. See you on Friday.
See you then. Bye.
Thanks. Bye bye.
Bye.